Okay. Would you mind giving just a brief background and intro on yourself, and then we can just start rolling?
Yeah, sure. Hi, everyone. So I am Greg Hartley. I am faculty at the University of Miami, Miller School of Medicine in Miami, Florida. And I am a board certified geriatric clinical specialist. I'm currently vice president of the Academy of Geriatric Physical Therapy. I was formerly most recently the president of the Academy of Geriatric Physical Therapy. I have been involved in residency education since its inception, and I chaired the accreditation board twice. I think I'm the only person who's ever done it twice. And I still do accreditation stuff for them fairly routinely. Yeah, I guess that's about it. That's enough.
Perfect. So I would say maybe we could go with the route you're talking about of giving maybe the big background overview of the residency education.
Sure. So, are you able to let me share my screen?
Yep, just did it.
Okay, cool. All right. I know this is not the presenter view, but it's going to need to work because when I put it in presenter view, I lose the ability to see other things. So, and I've started this presentation kind of in the middle of something that I had already done at a National Student Conclave before. So let me start off by saying, just talk a little bit about professional development in general. So once as a physical therapist student, you're going to graduate with a doctorate in physical therapy. So yes, it is a terminal degree, but your education really has just begun. And this is part of the argument that I made in the paper, Residency Education Now or Never, where you heard or saw us refer to the term basicist, sort of in contrast to the term generalist, really to try to elevate the term generalist. So I think that as an entry-level physical therapist, you will graduate with enough knowledge to be able to take care and manage basic patients across a variety of different settings. But there is absolutely no way in my mind that in 2021, with the volume of information that is coming out, with the amount of evidence and information that gets published on a daily basis, I think it is impossible for you to know everything about everything. And it's unrealistic for faculty or the profession to expect you to know everything about everything. And so as you graduate, you will have a responsibility to stay current and to expand your knowledge. And many of you will find yourself diving deeper into very, very specific areas of practice. Some of you will gravitate that way just naturally. Some of you will gravitate that way because it happens to be where you work. So for example, if you work in a children's hospital, then you are practicing in pediatric physical therapy. If you work in a skilled nursing facility, then you are practicing in geriatric physical therapy. If you work in an outpatient sports clinic, then you're practicing in orthopedics or sports or both. So you kind of get the idea. But you will have to maintain your licensure, your competence, and continue with your education in one way or another, choosing whatever specialty area that you want to tend to focus on, right? So one way to do that is through continuing education, which is by far the most common way that people stay current. And my advice to students is just be careful about choosing Con Ed. There's a whole lot out there. It's a very lucrative business. There's lots of gurus out there. Look at when you are shopping for a course, look at who's teaching it look at their credentials. Is it a physical therapist teaching it, or are you learning something from somebody who's not a physical therapist? So how can you learn physical therapy from someone who isn't a physical therapist? The answer is you can't. Um, and also look at who is the course directed towards. Is it a course that's open to PT and OT and speech and personal trainers and massage therapists and so on and so on? Or is it only open to physical therapists and physical therapist assistants? You can expect very different content if it was one versus the other, right? So you just kind of have to shop around with that. The other thing is there are many kinds of certifications that you can get in physical therapy. Board certification, which is part of where this conversation is going to go, because that's what residency education does, is prepare residents for board certification. And board certification is administered in our profession by ABPTS, the American Board of Physical Therapy Specialties. And they oversee the process, which includes a second examination. After you become licensed as a PT, you would take a second examination to become board certified in a particular area of practice. You can do that currently two different ways, either by completing a residency or by challenging the exam on your own without doing a residency. And we can talk about that a little bit later. There's all sorts of other certifications, and I know that you see these all the time, and some of them are very well respected by our profession. Some of them are less respected by the profession. And so just, again, sort of shop around and make sure that you're doing it for the right reasons. The alphabet soup is just one of my little soapboxes. It kind of bugs me because I think it looks a little bit desperate after a while, to be honest. I am someone who believes that DPT is enough, and we don't need to add 25 other initials after our names to look special. And these are actual real people, frankly, that I just changed their names. So I would challenge you that many of you on this call probably don't know what some of these initials stand for. And I can tell you that your patients have no clue what they stand for. And so it really just serves to stroke our own egos, or I frankly don't know what it does other than confuse the public, to be sure. So I want you to think about how that looks to the public. Now, APTA did pass resolution so that within the APTA, it no longer recognizes all of those alphabet soup of initials. There is a limited number of abbreviations that are recognized by the APTA. Now, understand APTA is not the abbreviation or credential police, so they can't stop you from using it, but they won't recognize those initials on their website or at conferences, like on your name badge or anything of that nature. And the idea is to try to get people to adopt this behavior on their own. You also have to think about OCS as board certification for what, right? Because it could be either orthopedics or oncologic. Those are two areas of board certification in physical therapy. So we no longer have those three initials that are associated with board certification anymore, not for any specialty area. Not for geriatrics, which used to be GCS, or PCS for pediatrics, or SCS for sports. All of those went away. For the main reason was because nobody knows what they stand for except for us. And the second reason is because of this confusion that exists with the letter O, which oncology is now an area of board certification for physical therapists. So those letters went away. And if you think about what physicians do, they don't use letters, and they get certified all the time, right? They are certified in every surgical procedure they do. Every time a new knee prosthetic comes out, your orthopedic surgeon has to go get certified in how to put it in. And they don't add 20 initials after their names after every Con Ed course they go to. MD is enough. And if they are board certified, they spell it out below their name. There aren't initials to abbreviate that you're a board certified orthopedic surgeon or a board certified cardiologist or internal medicine or whatever it might be. So I would challenge you to sort of limit the number of letters that you want to put after your name. The one exception is sometimes you do see the fellow status added after people's names, because Charlie Brown here would be a fellow in the American Academy of Orthopedic Surgery, right? Those are usually high honors and distinctions, and APTA does recognize one of those, which is the FAPTA, and then that's it. All right. So something to think about. I already said this about that I think DPT is enough. And then moving on into board certification. So ABPTS, the board, American Board of Physical Therapy Specialties, oversees this specialization process. And currently you can get board certified in all of these different areas. So cardiovascular, pulmonary, clinical electro, geri, neuro, oncology, orthopedics, peds, sports, women's health, which is soon to become, I think, pelvic health, and wound management. So those are all the areas of available to become board certified as a physical therapist in this country. One thing is different about board certification for PTs than it is for medicine. So if you think about it, physicians are all board certified in something. That's because residency education is a requirement for physicians. So they graduate medical school and they all end up with an MD if they graduate. But they still can't practice yet, because they must then go into a residency and choose an area of specialty practice, whether it's dermatology or internal medicine, or, they have 26 different specialty areas that they can enter, and they pick one. And then they have to pass a second exam after 1 year of residency, and then they have to pass a third exam when they finish the residency, before they are actually allowed to practice independently without any supervision or oversight whatsoever. So physicians have to complete residency education in order to get full, unrestricted, unfettered licensure in the United States. And it's also notable that no hospital will add a physician to their staff roster unless they have completed a residency. And furthermore, almost no insurance company will insure a physician that hasn't completed a residency. So it is for all intents and purposes, mandatory for physicians. In physical therapy, it's not, right? Board certification is voluntary. You can choose to do it or not. It is also non-restrictive. Now, what that means is, I'll give you my own example. I'm board certified in geriatrics. That does not mean that I can never treat children. I can. It's legal for me to do it. It's not a good idea for me to do it because I don't know anything about pediatrics, and I haven't been to a pediatrics con ed course in 30 years. It would be a terrible idea for me to treat a kid, but that wouldn't make it necessarily illegal. However, in medicine, I don't think you want your pediatrician doing your open heart surgery. So it is restrictive in medicine, whereas in physical therapy, it is not. And currently we do have, this number is a bit dated. We have got 30,000 PTs that are board certified in this country. And currently you can do board certification two ways. One is complete an accredited residency. That's the fast track. Or you can do it on your own. So if you do it on your own, you have to attain all the clinical hours without any mentoring. You just attain the clinical hours on your own. And you have to assume that you are studying and learning the right stuff, because you will still have to sit down and take the specialty board exam when you are ready. So let's focus on the clinical residency stuff. So or at least the clinical residency route. What is residency education? It's really a formal training post-professional or postgraduate from PT school. It builds on your foundational knowledge. So again, you have basicist, graduate PT, to specialist, which is where we're building on that knowledge. It facilitates all of this proficiency. So it takes you, in my mind, from being a competent physical therapist to being a proficient physical therapist. So what the heck's the difference with that? So I want you to think about the words. Competent, I think everybody understands what that means. It means you're not going to hurt anybody, you're safe, you can do it, you know enough to get people better, and you won't hurt them, right? So that's kind of the low bar, but that's what competent means. Proficient is somebody who gets people better in the context of physical therapy now. So it's somebody who gets people better, but does it in an efficient way so that it is not wasteful, so that you do it timely, you use resources wisely, you don't overtreat, you don't undertreat. You get better, you get people better faster, right? That's efficiency that's built into the system. And isn't that what every payer in America wants? They want you to get people better faster using fewer resources. And as payment models begin to shift towards value-based purchasing that incentivize less treatment, not more treatments, it is this efficiency, or arguably proficiency, that will become a very highly marketable skill. So in my mind, this is really where we have to get as a profession to become efficient in our service delivery. All right, so that's sort of what residency education is designed to do, to get you to that level of proficiency. So it takes you from entry level to specialty practice. And residents do have higher passing rates on the board exams, and I'm going to show you that data in a moment. Now, fellowships are different than residencies because fellowships are subspecialties. So where a residency would teach you everything you need to know from A to Z within a broad specialty area. Let's take pediatrics as an example. A fellowship would go deeper into a very niche area or subspecialty area of pediatrics, for example, NICU, right? So that's one example. In order to do a fellowship, you either have to have completed a residency. In my example, you would have had to complete a pediatric residency, or you have to enter the fellowship already board certified in pediatrics. So in other words, you don't skip residency to go straight to fellowship. You have to have the broad specialty knowledge before you go deeper into the subspecialty area of practice. And this graphic kind of illustrates everything I've been talking about. As a student, you're learning foundational material. You then graduate as this new graduate that is this generalist or basicist. As a resident, you get a little more narrow in your breadth, and you are learning to become a proficient specialist. And then as a fellow, you are approaching high proficiency or expertise, but within an even more narrow focused practice area. So that's what this is. And this slide really just gives you another way to think of it. As an entry-level PT, you are learning a little bit about a whole lot of stuff, right? So it is a very big but shallow pool, okay? So you're learning a little bit about a lot of stuff. Residency education is still a pretty big pool, but it's a little bit deeper, and you're getting a little bit better in that pool. Fellowship education doesn't have to be a very big pool. In fact, it's pretty small, but it better be deep, right? So it's extremely deep, but not as large in terms of area. All right, so residency education, there's a number of areas in which you can become trained in residency ed. And you will see that the list for residency education matches the list for board certification, with the exception of acute care up at the top. That's why it has the little asterisk. So you can do a residency in acute care, but there's currently not a corresponding board exam for specialty in acute care. However, that petition has been made, and I expect that we will have board certification in acute care and physical therapy within the next probably 3 years. So all the other areas of residency training correspond to a board certification area. For fellowship, you can see them listed here. We have critical care, which is a subspecialty of acute or cardiovascular. You have hand therapy, that's a subspecialty of ortho. Movement system, a subspecialty of neuro. Neonatology, I already told you, is a subspecialty of peds. OMPT, a subspecialty of ortho. Performing arts, also ortho. Spine, also ortho. Sports D1, obviously sports. And then upper extremity athlete, also subspecialty of sports. The upper extremity athlete fellowships are all with professional baseball teams. And the performing arts ones are with like the New York City Ballet, Cirque du Soleil. There's some pretty cool things. All right, so why residency versus just doing it on your own? Residency is mentored versus trial and error, obviously. In a residency, you're going to get 4 hours, at minimally 3 hours, but typically 4 hours of one-to-one direct mentoring every single week for the entire year. And that one-to-one mentoring is usually done by another board certified specialist in that specialty area. And so it is highly intensive in terms of your mentoring that occurs over real patients, not simulated ones, in real life, in the context of actual practice, which makes it so valuable. It's planned in the sense that you go from simple patients to increasingly complex patients. And you also generally go from more simple diagnoses or body parts to more complex diagnoses or body parts. And then obviously residency programs are accredited, and so they have to meet a variety of different accreditation criteria, just like your entry-level PT program does as well. And so don't get me wrong, residency programs are not glorified internships. These are not just things that you do when you graduate, and the program shouldn't see itself as such. A residency program is an accredited post-professional program, in the same way that you have an CAPTE accredited professional program that you are enrolled in today. Post-professional programs are accredited in the same manner. There's a lot of benefits to residency education. Patients understand it. Patients actually want it. Patients they appreciate having specialists take care of them. And physicians understand it. They get it. I mean, when I got board certified in geriatrics, there were no residencies. I started the first geriatric residency in the US. There weren't residencies for me to go to when I went through the board certification process. And so when I tell a physician that I'm board certified in geriatrics, usually one of the first questions that comes out of their mouth is, "Oh, that's cool. Where'd you do your residency?" I'm like, I didn't do a residency. They're all, "What? How do you get board certified in a specialty? You didn't do a residency." It is just the medical model. They understand it. Physicians value this. And I can tell you that when we started our residency program in geriatrics, our referrals to our outpatient centers doubled in 3 years, because physicians really appreciated the knowledge of knowing what was going on in the clinics. They understood the training that's happening there, and they believe that it elevated patient care. Yeah, okay, great. But do employers actually value this? In other words, does it pay to go to residency or to become board certified? And I would direct you to a study done by a colleague of mine, Matt Briggs, who is a co-author on the more recent of the two articles that I gave you. And they looked at whether employers saw a difference in residency trained or fellowship trained employees. And the employees were matched based on years of experience. So they were comparing apples to apples. And they had a huge response rate, 40%, 184 employers responded. And they rated residency and fellowship employees higher in leadership, communication, clinical aptitude, scholarship, evidence-based practice, and teaching when they were compared to experienced matched colleagues. So employers recognize and see a difference. I'll tell you that translates into increased opportunity. What ends up happening is because employers see all of this excellence in leadership or in clinical aptitude or in evidence-based practice or in teaching, any of those things, generally what happens is that these individuals are selected or invited to lead teams or to lead clinics or to manage programs or to manage students or to manage all sorts of things, which generally involves some sort of promotional opportunity. So that you see residency graduates being promoted into higher positions with increased responsibility and obviously commensurate increases in salary. So yes, there is an increase in pay. We're also seeing too now that by virtue of becoming board certified, employers are in some cases are just flat out giving raises to people who have become board certified. But what I see in general is increased opportunity and promotional ability so that your position description changes and your salary changes. So you might be asking, how do I pick a specialty now? My advice is to explore as much as you can when you're a student. Try to plan your clinical experiences to give you variety. I believe that there are a handful of students who know exactly what they want to do when they enter PT school. And it is the reason they went to PT school, and their mind never changes during 3 years. Those are almost always pediatric therapists for whatever reason. But most students don't have that experience. Most students go into PT often thinking they want to do sports and ortho because that's usually how people learn about PT. And then they discover, gee, I think I might like acute care, or wow, this cardiopulmonary has me turned on, or neuro, it really excites me, whatever it might be. So I would just say explore, give yourself variety in your clinical experiences if you can. That is to say, give yourself variety in the level of acuity. So you do some acute, you do some outpatient, and give yourself some variety in diagnostic categories, neuro, ortho, geri, etc. Also join an academy of the APTA. You can join the Academy of Orthopedic PT, the Academy of Sports PT, of Pediatric, of Geriatric, and so on and so on and so on. There are 18 different specialty academies within the APTA. And as students, it's dirt cheap to do that. So now is the cheapest, most economic time for you to join several sections and academies so that you can explore what's going on in that specialty area, who are people I can connect with and network with. And that's a really great way to learn about a specialty area. So as of just 2 days ago, I checked the numbers, and there are 329 residency programs and representing 6,062 graduates since residency educations really became a thing and began to be accredited back in 1999. So there are more residency programs than there are PT schools, but obviously the residency programs are smaller. in by and large. And you can see that this has grown a lot since it started. It continues to grow very quickly. And so in some time, we will reach that tipping point where we will have enough capacity in residency education to have a serious conversation about whether or not residency education should be a requirement and not an option. But we have a capacity issue right now, so that conversation is happening, but it's impossible until we meet capacity, or capacity can meet demand. So you might be asking if residency education is better than doing board certification on my own. And so here are pass rates. So these are all board certification exams together. So Jerry, Peds, Ortho, Sports, everything together. If you look at people who took the board exam on their own without doing a residency, the pass rate is the blue bar, or that teal colored bar. And people who completed a residency and took the board exam, their pass rate is the gray bar. So every year since residency education started, there have been increases in the pass rate for residents versus people who do not do a residency, to the point that it's sort of stabilized around 90%, which is really high. And then our non-board certified folks have stabilized around 80%. Here it is broken out by specialty area. So if you look at ortho, for example, in 2018, if you didn't do a residency, 79% of those people passed the board exam. If they did do a residency, 90% passed. In 2019, 79% again who didn't, and for residency, it was 87, just a little less. For sports, you had only 61% of people who did not do a residency pass the sports exam in 2018. But those who did do a residency was close to 90, so 87%. And then in 2019, you're seeing similar results, 74 versus 92. So there is a significant difference between the two. Now, this gets us to the paper, which I think was kind of the point of today's talk. So this was a paper that I authored with colleagues, Kathy Roach, Kendra Harrington, Stephanie McNally. And this was published in 2019, but the data goes back all the way to 2010. And we wanted to see if it mattered what kind of residency program you went to. There is a lot of variety in physical therapy in terms of types of residency programs. There are residency programs that are housed in academic entities that also have entry-level PT programs, like where I work at University of Miami. We have an entry-level PT program, but we also have accredited residencies in orthopedics, sports, geriatrics, pediatrics, neurology, and cardiovascular pulmonary, with plans to expand into every specialty area as we are able. So those residency programs are tightly associated with the academia of the University of Miami and its clinical facilities. There are also, and so many residency programs exist in that model, right? Like this academic model. There are other residency programs that are clinically based and are not affiliated with academic entities closely. An example of that, a clinically based program that isn't part of an CAPD academic kind of program, would be Mayo Clinic or Cleveland Clinic, or some of the Kaiser Permanente programs out in California. These are clinically based residencies that aren't tied to a PT school somewhere, but they still offer this accredited post-professional opportunity within their clinical structure. Okay. There are some programs that are a hybrid of that. So really tight partnerships between a clinical entity and an academic institution. And then lastly, there are what we called in this paper, non-clinical, non-academic. So there are residency programs that are neither of those. They are neither housed in an academic institution, nor are they housed in a clinical institution. And these are programs that are run by companies that honestly are continuing education providers mostly, but they also organize, administer, and oversee residency programs as well. But they do not have themselves their own clinics, and they are not also CAPTE academic entities.
I have a question.
So, yeah.
That seems a little sketchy. Does that, I'm assuming that's not how it is in med school, in medical residencies, right? They don't have that availability or that option.
Yeah, that's right. They do not accredit those types of programs in graduate, what they call graduate medical education, which is what we are calling post-professional PT education. They don't accredit those types of programs in med ed. Pharmacy almost did, but pharmacy has also not accrediting those types of programs. But in physical therapy, we have, and it was based on older models that came mostly out of the orthopedic manual therapy fellowship world, because a lot of those orthopedic manual therapy fellowships were very tightly affiliated with continuing education providers in that special subspecialty area. And as residency education grew, it became also an option or a model or a way people thought about delivering residency education in physical therapy as well. And so it happened. And those programs met criteria to be accredited, and so they were accredited. And so, yeah, they are still out there. So this study was really designed to look at, was there a difference in outcome based on that model? That was a huge purpose of this study, was, does it matter if you go to a program that's housed in a CAPTE academic kind of situation or a clinical situation like a Cleveland Clinic model, or something that is neither of those, right? So that was really a huge motivation behind the design of this study. So we took data from 2010 to 2013, which was in at that time was the most recent data we could get our hands on, which it's gotten a little bit better now because data is more automated, but back then it wasn't, and a lot of this had to be done by hand. So we looked at 183 residency programs, which in 2010, that represented 100% of residency programs. So I want to be clear, we didn't have a sample, we had the universe. So there is no power issue in the statistics. The statistics are the truth, right? It is the universe. There wasn't a sample here. We had every residency program in the United States was included. And we looked at every single graduate of every single program during that period of time. Again, the universe, not a sample. We looked at it, were you attending a program that were single site? So single site means you go to a clinic and you stay in that clinic for the entire duration of the residency and you never move. All right, that's pretty clear, single site. Multi-facility means you might rotate around in a year. So I might spend, for example, I'll show you our Jerry program. They spend 4 months in acute rehab, 4 months in subacute SNF, and 4 months in outpatient. It's all within the same entity, but they move from clinic to clinic. But at the end of the year, every single resident has gone through all 3 clinics in the same, with the same kinds of patients, with the same instructors in a different order, but they've all done and had the same experience at the end of the year. And the third type is multi-site. Multi-site is when you have resident A at a clinic in the north part of town and resident B at a clinic in the south part of town, and they do not rotate. They just stay in their own clinics the whole time, right? Now, I said the north part of town and the south part of town, but we have residency programs that have resident A in Bangor, Maine, and resident B in Los Angeles. They're in completely different states, right? And so the point is their experiences could be vastly different from each other, right? Not that they are, but they could be. So that was one of our main characteristics, is what was the clinical structure of your residency? Single site, multi-facility, which really is the same thing, or multi-site, right? We also looked at whether or not they provided live in didactic instruction or remote didactic instruction. Remember, this was 10 years ago, so there was no forced remote education. We looked at whether or not they charge tuition. So this might be a question some of you have. Most residency programs do not charge tuition. You are paid as a resident, right? You're making an income. You're not paying for this. They're paying you. So it's a different kind of model. We'll talk about that later. There's usually questions. So we looked at whether or not they charge tuition, and we looked at how much they paid a resident. Was it more than, equal to, or greater than 70% of what they would have paid a regular new grad PT? Okay. And we chose that number because that was the median. Our data was bimodal. Basically, half the programs paid less and half paid more, right? And then it turns out, if you went to a program that was single site or multi-facility, again, sort of the same kind of idea, and provided live instruction and did not charge tuition and paid residents more than 70% of what a typical PT would make, they were 9.8 times, almost 10 times more likely to graduate from the residency, 5 times more likely to become board certified, and 3.2 times more likely to pass the exam on first try. So collectively, those characteristics were the characteristics that mattered most. Now, we also looked at, when we put our model together, we looked at these characteristics, which I described to you already. But in addition to the first 3 that I talked about, we also looked at whether or not it was a full-time versus a part-time program. And we looked at program size. Was it a small residency, which was defined as 4 residents or less? Or was it a large residency, which was defined as 5 or more residents? And then lastly, we looked at administrative structure, which is what I started this conversation with. Was it academically housed? Was it clinically housed? Or was it neither of those things, right? So that's what administrative structure means. And so here's kind of what we found, and this data is all in the paper. But it turns out that, again, here is the type 1 programs down here, which are those programs that are single site or multi-facility, all live, no tuition, greater than 70% FTE, did not have a part-time option, and were either academically or clinically based. In other words, we pooled, if you were academic or clinical, we put you together. And if you were something else, you were something else. And the reason we did that is because it turns out, even though there were very few programs that were non-clinical and non-academic, it turns out there's a lot of residents that go to those programs. So the number of participants in each of these groups was similar, even though the number of programs in the non-clinical, non-academic group was very small compared to the number of programs in the academic and clinical pile. So it turns out type 1 programs were 9.8 times more likely to graduate, 5.1 times more likely to become board certified, and 3.2 times more likely to pass the board exam if they took it. It is important to know that by itself, clinical site structure, which is single site, multi-site, or single site, multi-facility, or multi-site, the clinical site structure was the most important factor in whether or not you pass board exam. And then in regression analysis, which isn't on a slide here, what we looked at was odds of graduating. The most important factor was the administrative structure. So if you went to an academic or a clinically based program, that was the most important factor in whether or not you graduate. Also, it was the most important factor in whether or not you would become board certified. And then the most important factor for whether or not you passed the board, if you decided to take it, turned out to be the clinical site structure. All right. So that was the data from that particular study. You can go to the ABPTRFE website and learn a whole lot more. In fact, I think I have it pulled up here. Yeah. You can go here and you can, for example, look at 4 participants and get lots of information here. You can also look at a directory of programs, and you can search programs based on specialty area, based on your geographic location. And once my really slow computer loads, you will see that you are also able to sort this data based on clinical site structure, academic structure, how much they pay a resident, et cetera, et cetera. So here we go. If you just click on the advanced search, you'll see you can search by state, you can search by type of program, and here you see that language that was in our study: single site, multi-site, multi-facility. You can search program format, part-time, full-time. You can search, do they charge you tuition or not? You can search, is it live or remote? You can search what specialty area it is. You can search, who is it affiliated with? And who's my sponsoring organization? Is it a CAPTE school? Is it an outpatient office? Is it something else? All right, so these search criteria were actually created because of the study we did. So if you decide you want to look at, for example, let's do orthopedic programs in Texas, then it's going to pull up. I know you have orthopedic programs in Texas. Texas orthopedics. Well, I don't know why the search isn't working unless their website is just having a glitch, but that's the way the site should work. Anyway, all right, could just be my computer being glitchy.
Yeah, I tried it on mine and it works.
It works.
It's the same with yours. It like didn't pop up initially. So
yeah, all right. Okay, cool. So that's how you can search and sort in the ABPTRV website. This is just a picture of that, and so that's that. All right, so that, I guess, kind of summarizes an overview of residency education itself, and what its purpose is, how you learn about it, how as a student you begin to conceptualize this. So that's really just the nuts and bolts of what residency education is and how you find it, and etc. My thoughts educationally around residency education are probably the more provocative topic. I mean, because this topic is, that's bread and butter. So the more provocative topic is really, I think, what's in my head about education and where education is going. So let me just open that conversation, and then I will entertain questions on all of it. Okay. So my thoughts on this are, you've heard me refer to the term, or use the term, basicist before, which I think is not meant to belittle anything about what a new grad PT knows. It's just, I think, gives it a legitimate name of, you have basic information about a whole lot of stuff, but you haven't really fine-tuned your skills, your expertise, or your proficiency in any single area on the day you graduate or the day you get your PT license. And so there's a whole lot of learning that occurs in this immediate post-licensure period. And you will learn and absorb no matter where you are. And you can put yourself in a really great environment and surround yourself by mentors who have been trained to teach you to think in ways that will help you build what we call movement scripts, meaning that when you see a pattern of movement in patients, and you suddenly know exactly what to do. You hardly even think about it. It happens in the blink of an eye. This is what experts do. Expert practice lets you make these really big leaps cognitively. And if you ask an expert to explain how they got from point A to point B, if you watch a really master clinician treat a patient and you wonder what's going through their head, and you recognize that they went straight to the problem, that they got right to the right diagnosis the first time, that the intervention was appropriate and it worked the first time. And so you say, gee, that's what I want to do. And you ask that person how they did that. How did you get from point A to point B? It is almost always the case that they cannot tell you. They don't know. It just happens. This is pattern recognition, forward reasoning. We learn this in the context of practice. We learn it in the practice environment. You do not learn this in a classroom. You learn it in a clinic. And you learn it through repetitive exposure to the same kinds of patients over and over and over again, to where you build these patterns and you're then able to make these mental leaps. Now, that kind of exposure is best applied when you are mentored by people who are already there, by people who can already do that, by people who know how to ask you the right questions to train your brain to work in that manner. And so that's really the value of what residency education does, is because those mentors have a vested interest in teaching you exactly how to do just that. And they also know how to teach you to do just that. If you weren't in a residency and you were practicing in a clinic on your own, you are still going to learn these habits of the mind. You're going to learn them. The problem is that they can be bad habits. You don't always learn good habits, right? You can learn bad habits just as easily. And so putting yourself in the right environment with the right people, particularly your first job right out of school, because that first year is critical. It will impact the way you practice for the rest of your career. It is the most important job you will ever have, your first job. So choose it wisely. And that is why I think residency education is so important to our profession. As we, as doctors of physical therapy, are in this space of primary care and treatment without referral and medical screening and imaging and all of these things that are coming to us, we cannot know everything about everything. We have to choose something and get really good at it. Otherwise, we are inefficient in a lot of different things rather than being efficient in one or two things, right? So I think residency education really is the future. And because you have to learn this way in the context of clinical practice, it doesn't happen in a classroom, then I think we really have to look at how we begin to restructure our educational model. So I have proposed a few ideas. I threw this out first in a report that was called the Best Practice in Clinical Education Task Force report. It came out in 2017. It was a task force that I was on. We worked for a year and a half trying to come up with what we thought was the best model to represent a continuum of learning in PT education that would include professional level education, which is entry level, and post-professional level education, which is residency. And what we came up with was this concept of shortening your didactic training, condensing it, getting it down to something that is manageable, because and recognizing that as faculty, we do not have the responsibility to teach you everything. And we shouldn't have the responsibility to teach you everything. We should have a responsibility to teach you basic information about all of it, but not in-depth information about any of it. That's my opinion. And so I think if we had that mentality of we're going to teach you basic information about all of it, then we can do that in less time. I also think there are some superfluous courses in many PT programs that can just be gotten rid of because they're either advanced or potentially no longer even applicable. And so that could be reduced. There's timing, there's other things that happen in different PT schools that I think overall we could condense our didactic training down to eliminate some time in the classroom. Then we would extend the time in the clinic. So you would still need to do clinical internships, or I think they don't call them that anymore. They call them terminal clinical experiences. So you would still do that as a student under very close supervision, so that a clinical instructor would observe you and attest that you were trustworthy to enter the clinic, meaning that you were those things I described at the beginning. You were safe. You're not going to hurt anybody. You're not going to hurt yourself. You're safe. And you have a basic level of competence to get people better. You may not be really efficient or proficient yet, but you're competent. And I trust that you can do these things without me watching you all the time. I can leave the room and I trust that you're going to be okay. That's the goal of entry-level education. So those are called entrustable professional activities, EPAs. It's a big conversation happening right now in medical education. They're doing the same thing in med ed that we're doing in PT ed. So if we could focus our energy on the entry-level side to condense didactics and then focus your clinical experiences on achievement of these entrustable professional activities so that you become competent, then you enter residency education, not by choice, but as a mandate. and you do residency education in a chosen or selected specialty area of practice. Now, what has to change is we must have the equivalent of general practitioner or primary care practitioner or internal medicine or family practice, what they have in medicine. There's 3 different specialties that are all considered GP. That's primary care, internal medicine, and family medicine, right? So we don't have the equivalent of that in physical therapy yet, but I will tell you that that idea has already been proposed to ABPTS, the specialty board, and so I know that it is coming. So soon we will have board certification in general practice, because there is definitely a role for that, and I think it's as worthy of specialty practice, because to be a true, really good generalist requires additional training. So that's coming. And once we have a generalist or a primary care sort of area of specialization in physical therapy, then, and we also increase our capacity, then I think we can have a serious conversation about, does this need to be mandated? So I want you to think though about time. So time in school right now is 3 years for almost every PT school, a few exceptions to that. What I'm proposing and what we have proposed, it's not just me, it's several people are thinking this way, is that didactic education would go down to say 2.5 years at most. Maybe it could be squeezed into 2. And so that's the time you pay tuition. Then you graduate, and then you do a residency program for a year, which you don't pay tuition for, but you get paid. So your total time of training is still 3 years, roughly, but you're only paying tuition for 2 years of it. And you're making an income for the 3rd year, and your student loans during that 3rd year are deferrable because you're still enrolled in an accredited educational program, right? Which, by the way, most student loans, depending on your type, most student loans you can defer even today if you are a resident in a residency. All right, so that's a model that has been thrown out. The Best Practice in Clin Ed Task Force put that model out there in 2017, and it was a complete flop. Nobody got as energized about it as the people who were on the task force did. And it resulted, though, in the creation of something called the Education Leadership Partnership, which is a bunch of ships, but it is the Academy of Physical Therapy Education, ACAPT, which is the American Council of Physical Therapy Academic Institutions, so PT schools, and CAPTE. So those 3 entities came together to form this education partnership group. And they have really begun to have conversations in earnest about how education can change in this country. In the end, you know, what really was the reason we went from a master's to a doctorate? I mean, we wanted to have direct access. We needed the doctorate to be in that space. Everybody knew it. We have been talking about it for decades. We need to get a doctoral degree so we can enter the space of primary care, so we can enter the space of direct access, so we can be at that level. But the thing that made it happen was the market. The market drove creation of DPT programs, and it will be the market that drives creations of additional residency programs. So I think we'll get to that tipping point at some day, and then we have to see where the profession goes with this. Nothing will change on the post-professional end until we change the entry-level end, and vice versa. And what I've proposed is very complex because it would require staged licensure. Understand, the only way to mandate residency education would be to give you a restricted license when you finish PT school. So that's staged licensure. So you'd have to have 2 licensure examinations. But they have that in medicine, right? They have 3 in medicine. This is how it's enforced in every healthcare profession all across the world. That's so there's a lot to this, right? It's not a simple thing, right? There's a lot to it, but it's a great conversation. So let me shut up for a while. What do you guys want to talk about?
All right, I'll go first. Dr. Hartley, thanks for coming on.
Sure.
This is really cool. Just as a student right now, I'd obviously agree with a lot of your statements. I guess just as I'm looking to graduate in the summer of next year, I think one of the harder things for me to sort of decide is, okay, when would I want to do a residency program? I kind of struggle with the timing of that, and I'm just curious to hear your thoughts. Do you go out, you flounder in the waters for a little bit, and then you realize you can't swim, and then you find an instructor, or do you go through a structured program from the start?
Right. Terrific, really good question. There are different schools of thought on that, even within accredited programs. Like some programs only want to accept people who already have a year experience under their belt. But most residency programs like to take new graduates. They will take people who have some experience, but they often will tell you that they like to take new graduates because, remember I said a moment ago that you can form bad habits. Residency programs directors will say some people who come with experience that they spend the first 4 or 5 months unteaching bad habits, and they'd just rather not do that. And so many program directors will say, I prefer a new grad. That said, not all of them will. Some program directors will say, no, we really want somebody with a little more experience. But by and large, particularly in ortho, sports, geriatrics, almost all the specialty areas with the exception of pediatrics and cardiopulmonary, those 2 tend to be the 2 that really, they often will say, I prefer people who have a little more experience. But almost all the other specialty areas will say, no, new grads, come on. That's who we want, is new grads. Now, that tells you what program directors will say. That's not your question. Your question is, does it make a difference? And I don't have the answer to that, but I will soon, because I'm working with a group of researchers that we have a grant to study that question, Kevin. So I've been collecting data for the last 1.5 years. It's qualitative data because this is the kind of research that doesn't have numbers attached to it. It's all qualitative. So we've been doing interviews with residency program participants for the last 1.5 years. And we have asked people who entered a residency right out of school and people who entered a residency 1 year or 2 years after graduating PT school. And we are in the process of coding all that data right now. We literally have hours and hours of recorded interviews to go through. But it's really pretty fascinating to see what they are saying about their experiences. They're having similar experiences. I only spoke to one person who waited to do a residency after she graduated and then regretted having waited. So, but other people waited and didn't regret doing it, but said the experience was absolutely totally worth it. So I don't know if statistically we're going to see any differences between the group, but I will tell you anecdotally, program directors often really like new grads because they're not having to unteach you stuff, right? That's a really good question.
Great, thanks.
Okay.
All right, I'll go. Oh, go for it, Lauren.
No, go for it. Go for it. Okay, kind of going off on the same topic, really. So we might be going in the same direction. So I was not early on, but advised to wait by some people that were in cardiopulm, so that makes sense. I think, I don't know. I think I wouldn't mind personally exploring a little more before going into something super specific. But I hadn't really heard that perspective. I mean, I heard the perspective that you can form bad habits, but I hadn't really heard the perspective that, I don't know, you're like kind of marked in this direction after your first year. Do you feel like you sometimes see people that maybe go back? And because I don't think I ever want to stop learning.
No, of course not. Of course not. So I would say a few comments about that. First, remember in physical therapy, specialty practice is not restrictive. So just because you specialize in cardiovascular and pulmonary doesn't mean you can't also see patients with neurological and orthopedic and geriatric and pediatric issues. So you're not restricted in practice because of a specialization. So that's number one. Number two, you can change. You can get dual board certified. I know many people that are geriatric and neurologic, or geriatric and orthopedic. Both. You can have dual certifications. Then another issue you brought up was, I don't really know because I haven't seen it yet. It's hard for me to pick. I think that was a flavor of part of your question. And that gets to what I alluded to earlier, but didn't really articulate, which is, I think it's incumbent on entry-level PT schools to give you broad experience across all specialty areas. Now in medicine, this is how they spend their third and fourth years. They do rotations through all 26 of those specialty areas. So, but sometimes they only get 2 weeks. They get 2 weeks of cardiology, 2 weeks of gastrointestinal, 2 weeks of dermatology. That's it. That's all they get, 2 weeks in some cases. And then at the end of 4 years, they have to pick one. And they may have only seen it for 2 weeks. So it feels foreign to us, but other professions do this all the time. It is a matter of fact. So it would be then incumbent on a new PT student to explore a lot, right? A lot more than we do now, because we don't have to make these decisions. But if you had to make the decision and you knew it on day one of PT school, you would start exploring on day 2 of PT school, right? You would really dig, you would explore, you would find opportunities to see kinds of clinics where you gravitated towards. And then ideally, your entry-level PT school would give you some experience in all of those settings or with all of those types of populations in your entry-level experience, so that you would be armed to make an educated decision about which specialty area you wanted to pick, right? So I think there's change that needs to occur on the academic side there. And then there has to be a shift in the psychology of students to say, all right, if I've entered PT school and I want to do a residency when I finish, then I need to decide a specialty. And I've got 3 years to figure out what it is, but I need to figure it out, right? But that's a shift in the way we think, because residency education isn't currently mandated or required in any way. So people aren't forced to make those decisions. Yeah. Gabe, welcome.
Hello.
Did you have a question?
Yeah. And it's probably going to put you in a position where it may be a provocative answer, but it just dawned on me and I'm
Oh,
curious.
that's good.
Earlier you mentioned how, given that you're certified in geriatrics, you don't think it would necessarily be the best idea for you to go treat pediatric population, but you're
Right.
not restricted to that.
That's right.
Assuming we ever get to the point as a profession where board certification is kind of like mandated,
Yeah.
What are your feelings on restricting access at that point?
So that's a really great question, and one that I've thought about, and one that comes up in conversation a lot, and it is tied to a whole host of things. I think, so let me give you a moral and ethical answer, and then I'm going to give you a financial answer. So the moral answer is yes, I think it should be restricted, because I don't have any business treating kids. None. So there is also this concept of scope of practice, right? And so you probably have learned a little bit about scope of practice is an upside down triangle. So at the top, you have, pardon me, you have professional scope of practice. So that's what the APTA and the House of Delegates and smart people there say. This is what PTs know. This is what they can do. Everything that they know, and it's A to Z. It includes all of it. That's professional scope of practice. And then below that, the next level of the triangle is jurisdictional scope of practice. Jurisdictional scope of practice is what Texas says you can do. And Texas might not say you can do all of that stuff that APTA said you could do. Texas might limit you. Some states limit, for example, dry needling, imaging, there's restrictions, right? So that's jurisdictional scope of practice. And then the highest tier, or I guess in my example, the lowest tier, the most restricted one, is personal scope of practice. Personal scope of practice is your own ethical moral compass. It is what you know you should do and what you know you should not do. And it's based on your own personal competence, confidence, and ability to demonstrate that you actually have been trained and have competence in that area. So let me tell you what would happen if I went and treated a kid and something really, let's say something bad happened. I treated a kid with muscular dystrophy. He was 5 years old and I didn't know what the heck I was doing and he got hurt. And I say, well, I didn't do anything illegal. Well, I didn't. But would I get sued? You bet I would get sued. Would I lose? You bet I would lose, because I couldn't demonstrate that I had personal scope of practice and was competent in treating a 5-year-old kid with muscular dystrophy when I have never seen that diagnosis in my entire career, right? So I would get sued and I would lose. So from an ethical and moral point of view, the answer to your question is yes. I think that if we get to a point where specialization is mandatory, and we can include Lauren's concern of, I haven't seen it all, so I don't know how to pick one. We got to fix that part of it, right? But we inform you enough to make an educated decision about which area you want to do. So you pick one wisely and you're happy with it, right? Then when we get there, then I think having a restricted practice makes ethical sense and makes sense for patients, because patients then get the best person to see their specific issue. Granted, we would still have this caveat over here of a primary care general practice PT, right? That would still have to be a thing. All right, so that's the moral ethical issue. Now let's do the financial issue. The financial issue is, in medicine, specialists get paid a whole lot more than primary care providers do. Their CPT codes are paid higher. Your copays when you go see a specialist versus your primary care doctor are double, if not triple. And the reason is because the idea behind that is that you see your PCP fairly frequently, and you should be encouraged to see your PCP frequently. So the copays are low as to not create a barrier, and also because you see that person a lot. A specialist is paid more because it is specialized care, but also your co-payments might be higher because you're not going to see that person many times. If you need to go have orthopedic surgery, you're going to see the surgeon once. They're going to do imaging. They're going to tell you the procedure you need. They might do surgery. They might then follow up with you 2 or 3 times after surgery, and then you're done. You won't see them again ever, right? So the co-pays are higher, but you're seeing them far less often, and they are not your lifelong physician. So it's different in that regard in physical therapy. And that concerns many people in our profession, because it is highly unlikely we are ever going to get more money to be a specialist. What the actual scenario would be is that the primary care general PT would get less money. And that's frightening to a lot of people for very good reasons. And so it is a slippery slope. I think there's one answer that is idealistic and is this, all fuzzy and flowers and, it's great. And this is the way we should do it. It's the touchy-feely side. It's real good. And then there's the realist side. That is, yeah, but that's a pretty dangerous path to go down. So it will be interesting to see where it all ends up. There's a lot tied into it. I think there's the patient expectation piece, there's the professional identity piece, and then there's this financial piece that is scary because I don't know what happens there, right? Yeah, it's a great question.
I mean, I feel like I agreed with like the ethical part of that, and I appreciate your answer.
Good.
I have a question, and I had talked to you about this before people got on, but like University of Miami, you said already has a ton of residencies, and they're about to, or the goal is to have all residencies available, and my university doesn't have any. And have you found the DPT students, like what is the average ratio of graduating students applying to residency? Is it higher because of, and I guess it's hard to compare, but do you all have a significant amount of people applying each year to residencies? Because I don't know of many of our like prior cohorts that have had more than like maybe 1 or 2.
Okay, great question. So nationally, on average, 20% of graduating PT students apply to residencies. So that is the national average. That's a terrific question about whether or not there is a difference in schools that house residencies versus those that don't. I don't have the answer to that. The data is there, but I don't think anybody has looked at that data. That's a paper, Chris. You can write a paper on that. But that's a really good question. I have a hypothesis that I suspect that it's higher at schools that have or house residencies, but that would need to be tested. So yeah, on average, about 20% of graduating PT students currently apply for positions, and that number grows every year.
I think the only enticing, the individuals I've talked to, it's what you talked about with the residencies that aren't affiliated with the clinical or like university aspect. They're kind of separate. Normally like the orthopedic residencies or fellowships, like there's so many around this area. I think that's the most enticing one, but that also seems to be the least impressive. And I know there's other programs in Texas that have residencies attached to them. So I'd be curious to know, like, do those students, they feel obliged? Do they feel like a sense of more of options because it's like they can visually see it or they can talk to the residents?
Yeah, well, I think because they visually see it, it's always there for them. Like, and at UM, just yesterday, I spent the entire morning doing systems-based practice lectures and education on healthcare systems and policy, and that's something I do with all of our residents. So we have classes where all of our residents go together because it's a topic that applies to the pediatric residents and the sports residents and the orthos and the cardios and the neuros and the gerries. And so all of them were there together. And in addition to them coming together for some classes, they also, our residents also teach in our entry-level program. So they do their lab techs, their TAs, they're doing open labs with students. They interact with our students a lot. And so our students get to see them not only as residents, but also as teachers. And I think that there is a value there that impacts potentially their interest in residency education. I do think that we do have to get to a point where, and if you read the newest paper that we just put out this year, the Residency Now or Never one, we have a call in that paper that every CAPP accredited PT school in this country needs to have residency programs. That is how we have to address the capacity issue. And that needs to be part and parcel of what entry-level PT programs begin to do, is they become not just entry-level PT programs, they become post-professional PT programs. And they actually shift faculty from entry-level roles to post-professional roles. Why? Because if you do what I was thinking and you shorten didactic down, you don't need as many faculty. So then you shift some of them to the post-professional side. So programs really have to think long-term and continuum in developing that kind of a model. And eventually I think we will get there, Chris, but you're right. I think some programs haven't yet adopted it. They may not be completely as sold on it as other programs are. Some programs have fully embraced it. You know, Ohio State, University of Miami, University of Delaware, Southern California, there's a few, Duke, I think, that they have lots of residencies in lots of different specialty areas. And I think those are models that will catch on over time, so that we end up with programs that span the continuum in that way. And that becomes fairly common. You also asked, and I don't think I answered, about how many people apply to our programs. I said 20% of graduating PT students apply. The number that apply to individual residency programs really varies. It also, I think, reflects competitiveness in certain specialty areas. Ortho is by far the biggest. You know, there's more than 100 orthopedic residencies now, and it will always be the biggest. I mean, this is physical therapy. It's always going to be the biggest specialty area, no matter what, ever. Sports is very likely always going to be a close second, right? So those two programs, just because they are the most popular specialty areas in PT, also attract the most applicants to our residencies anyway. And then we have plenty of people that apply to our other residency programs, but not nearly the numbers that apply to our ortho and sports.
My question was more so like the graduating classes in your PT program. Do you know what the rate, like, is it a higher than 20% average for the?
Oh, that apply? Yeah, our program has that data, but I don't know the number off the top of my head. I think that it's higher than 20%, but don't quote me.
So I have like two quick questions. One is, I know that I agree that there are things that need to be removed from the curriculum. Do you think maybe there are things that need to be added, such as pain science or strength and conditioning? So that's the first question. And the second is, do you think that the travel therapy industry would cease to exist?
So do I think things need to be added? Yes. Care and practice has evolved in the 30 odd years since I graduated from PT school. We're actually having conversations, and PT schools should normally have these conversations on a regular basis. This is generally why faculty go to an annual faculty retreat, where they sort of go into a cave somewhere and really dissect a curriculum and say, what needs to be taken out, what needs to be added. Our program is having that conversation 2 weeks from today on a Saturday to look at our curriculum. And we have made some changes internally in our curriculum where we have looked at adding pain science. We've looked at adding additional content on social determinants of health. We've looked at adding additional comments or content on systems-based practice, and actually have just created an entire new course that is it's called Systems-Based Practice in Physical Therapy. And so those things should be happening routinely in every PT program, and every PT program's curriculum should evolve. That said, there are CAPTE requirements that every program has to teach. There's flexibility, but there are still bottom line requirements that they cannot remove because it's an accreditation criteria. There are also content in curricula that are taught because you are still tested on it on the NPTE. So let me give you an example of something that I think should be removed from PT education, but is not. And that's therapeutic ultrasound. I don't know why we still teach you that. The evidence is, I do know why we still teach you that. And I'll tell you why we still teach you. But the evidence shows us that you can plug your ultrasound machine in or not and get the same result. It makes no difference if the thing is plugged in or not. So there is no value in therapeutic ultrasound, zero. The only thing it adds is cost. So that's what we know about ultrasound. Now, so why do we still teach you how to do it? The reason is because the way the NPTE is structured, the Federation of State Boards of Physical Therapy surveys practicing physical therapists routinely to determine what they are doing in practice. And they ask people, do you use this thing, this ultrasound thing? And they say, yeah, we do. And then the Federation says, well, you know what? If you're using it, we have to make sure that you're using it safely and you're not going to hurt somebody with the thing. Because ultimately, why do we have a license? It's not to test how smart you are. We have a license to protect the public. State boards grant you a license to protect the health and safety of Texans or Floridians or whatever state you have a license in. That's why you have a license, it's for public safety. So as long as there are PTs out there responding to that survey saying, yep, I use ultrasound, then it's gonna show up on your NPTE. And as long as it shows up on your NPTE, then we have to teach you how to do it. It's a vicious cycle, right? So hopefully one day you guys get out there, and when you get that survey, you'll say, no, I haven't turned on an ultrasound machine in 20 years, which is the case for me. I wouldn't know how to turn it on if you put one in front of me. So, and then eventually that content comes off the exam. Eventually that content comes out of curricula, and so on and so on. It just takes time for those things to happen. So that was, I think, part of your question is, should curricula be modified or changed? Then you had a second part, and I forgot what it was. Didn't you have a second part to the question?
It was related to travel therapy.
Oh, travel. Will travel therapy go away? No, I'm not sure how that is connected. Maybe it's not connected, but no, travel therapy won't go away. I will tell you that what I do with my students at UM is I caution them about taking a travel therapy job right out of school. And the reason has to do with what I told you earlier. Your first job will form how you practice for the rest of your career. It is where you will develop habits. It is where you will learn how to be proficient or not. And travel therapy pays well. And there is a lot of, you can make really good money, which is attractive to new grads with boatloads of debt. I get it. It's super tempting. But I want you to think about for a moment, who uses travel physical therapists for 6 or 8 weeks at a time? By and large, it's clinics who can't hire somebody full time, because those clinics are not choosing to use a traveler because it's more economical. I can promise you that. Having been an administrator who ran 9 practices for 10 years, we use travelers, but only out of desperation because they are crazy expensive. So the clinics who use traveling therapists are usually clinics who can't hire somebody else. And there's often a reason why they can't hire somebody else. People don't want to work there for a reason often. Either it could be that it's very remote, it's in an odd part of the country. That's geographic. That's a different thing. It could be a fabulous clinic, but it's in some remote area that nobody wants to live and they have a hard time recruiting, and fine, I get that. And then there would be clinics like the one that I worked at and ran, which was a great clinic, I promise you. But we use travelers really just to cover maternity leave. And that was one way we did that. Nowadays, folks use per diem people, and they really try to avoid using the travelers for maternity coverage because that's often just a 3-month kind of thing. But people who have long-term travel therapists in there, and they're in a part of the country that's desirable, you really have to think about, why are they using travelers? Because they're paying twice as much to have you there than they would pay if they could hire somebody there of their own. They're paying double to that travel company, and you're getting a big chunk of it, but that company's still making a big profit too. So there will be a place for travel companies because those kinds of vacancies will always exist. And travel companies will exist to fill those vacancies. My advice, though, is be very, very cautious about taking those jobs right out of school. As lucrative as it can be, and as fun as it might sound to get to move around the country, think about doing that a year later. Do something that first year that's going to take you from being a competent basicist to a proficient physical therapist. That's your goal right out of school. Do that. Then go have fun. Then go do what you want to, because not only are you going to be proficient and really good, you're going to be confident. Because often those travel positions, you are alone. You are the only PT in the clinic. There's nobody else there. So yeah, think twice about those travel positions right out. And for the same reason, home health. Think twice about that right out of school for the same reasons, really.
So I have another question, and it's related to the numbers. You've talked about how reimbursement rates, the incentive, you mentioned value-based care. And ideally, that's what insurance wants in a warm and fuzzy world. They want it to be more effective care. Do we have any evidence or you know, moving towards better reimbursement for people who have gone through residency or you know, they're certified in specialty practice?
So awesome question, Kevin. You're getting into my you can join my systems class later. So really good question. So this gets at what we were talking about earlier before about reimbursement or payment differentials between a generalist and a specialist, right? But your question isn't just, are you being paid more because you have more school or more credentials or a more specialized service, but are you being paid more because you get better outcome? And we do not have the answer to those questions yet. Ideally, through a data registry. Now, APTA has started a data registry that if people would participate in the registry, then all of this data would get poured into that registry and we would be able to answer that question. We would be able to say, board certified specialists get people better in who have, you know, persistent low back pain. It takes them 6 visits to get them substantially better on the ODI. And somebody who isn't board certified, it takes them 16 visits to get them better on the ODI, right? Or to reach the same point. We don't have the ability to really look at that data in any kind of scale. I mean, we've looked at it in like little microcosms, but not anything that is scalable. Ideally, once people begin to participate in the data registry, which exists, we will be able to tell that and be able to discern if residency training makes a difference, if board certification makes a difference, if years of experience make a difference, if where you went to PT school makes a difference. We'll be able to look at all of that, right? But we can't just yet. However, with value-based payment models, there are programs already in place. One example is merit-based incentive payment system, so-called MIPS, M-I-P-S. So the merit-based incentive payment system is already in place for outpatient PT, and they get bonuses if they achieve certain outcomes with patients. These are fairly generic outcomes right now. They aren't drilled down to all the risk, the different, cost benefit analyses based on diagnosis and comorbidities and age and all that. But basic outcomes, pain, falls, super basic things, achieving higher levels of care, reducing falls, reducing pain, reducing common outcome measures. And in clinics that are achieving these outcomes, they're getting bonuses at the end of the year. The flip side of that, though, because these payment systems are budget neutral. So that means if Kevin is getting a bonus, then Chris might be getting a cut. Because at the end of the day, it's just one big seesaw. So it's budget neutral. So for every clinic that's getting a 7% bonus, there are some clinics over here that are getting a 7% cut. Now that's not a bad thing, frankly, if you think about it from a sort of idealistic point of view again, is that you are incentivizing good behavior. You are incentivizing good outcome. You are disincentivizing bad behavior. You are disincentivizing bad outcome. So then the question becomes, Kevin, if I have board certified specialists on my staff, can I get those bonuses? Can I be in the pile of clinics that get the bonus payments and not the pile of clinics that get the penalty? So in that sense, value-based purchasing would reward efficiency and proficiency and theoretically expertise, specialization, advanced training, et cetera, right? Yeah, that's big picture stuff. That's good.
Does anyone have any other questions before we wrap up? I have one. What you mentioned earlier, I think to Lauren's question, or maybe it's Gabe's, where the survey for the ultrasound example where it's going to current clinicians. Do they do that in medical education where they
Yeah.
survey for the like USMLE or the boards?
Mhm.
Okay, got it.
Yeah. Yeah, that's how essentially all licensure exams for healthcare professionals are done. They survey practicing clinicians, and they get it from, it's not a list of APTA members. It's a list of licensed clinicians. So it could go to anybody with a license, and they survey them and ask those questions. And yeah, that's done in virtually every regulated profession.
Got it. Good to know.
Yep.
Well, thank you so much for being able to chat for almost 2 hours. This is great.
All right. That's all right. There's always great questions about this. It's such a hot topic, and one that I really care a lot about. So I'm glad that you invited me, and I enjoyed it.
Awesome. All right. Well, enjoy the rest of your weekend. Thanks everyone
Okay.
for joining the party. All right. Bye.
Thanks. Bye.